The development of this podcast was sponsored by Alexion Pharmaceuticals Incorporated. The viewpoints expressed are those of the person speaking and not of Alexion. Welcome to NMOSD Your Way Global, an educational podcast series for NMOSD patients worldwide. NMOSD stands for Neuromyelitis Optica Spectrum Disorder, a rare relapsing autoimmune disorder of the central nervous system which primarily affects the optic nerves and the spinal cord. Your podcast hosts Lesley-Ann Hall and Debbie Leticq, who have both lived with NMOSD for over 10 years, will be bringing their respective Canadian and Australian perspectives to the table in order to help patients worldwide better understand NMOSD. Over the next 16 episodes, clinicians, researchers, and fellow patients will come together to have important conversations about how to live your best life within your diagnosis. They will be offering up encouragement and practical tips for overall health and well-being. In this episode, Debbie is joined by neurologist Dr. Lesley-Ann Hall, and together they unpack some of the mystery behind NMOSD. So, let's get started.
Hello, listeners, and welcome to the podcast series NMOSD. And we're talking with Dr. Lesley-Ann Hall today. My name is Debbie Leticq. I was diagnosed with NMOSD 10 years ago. And at the time, it was very devastating. It was a very unknown disease. It took quite some time to get from the initial stages of the developing attack to final diagnosis. Back then, 10 years ago, there was not as much known about NMOSD. There were so many questions that I wanted the answer to, and I found it really difficult to get the answers to at the time. A lot of the stuff I found on Google, a lot of the information I found also and read about was quite frightening. I was very fortunate to eventually come across a supportive and small NMOSD Facebook page where we were able to finally, I think there was only 8 of us at the time, but we were finally able to share some of our experiences. So I'm hoping in this this episode with Dr. Lesley-Ann that we'll be able to unpack and learn so much more about NMOSD. And I know that it's come such a long way in the last 10 years since I was first diagnosed. I'm really pleased to be able to talk to Lesley-Ann today and to unpack some of the information around NMOSD. Thanks, Dr. Lesley-Ann Hall, for sharing your information and knowledge today.
Thanks very much, Debbie, for having me.
Can you tell us a little bit about your background?
Yeah, of course. My name is Lesley-Ann Hall. I'm one of the consultant neurologists working in South Australia. I've been working in the neuroimmunology sphere for the last 7 years now as a consultant neurologist, and that's involved managing patients with NMOSD for quite a while now.
Fantastic. It's so good to have you here. We're here today to talk about neuromyelitis optica spectrum disorder, or NMOSD. I live and feel the effects each day, but from a neurologist's perspective, what exactly is this rare condition?
Yeah, look, NMOSD, or Neuromyelitis Optica Spectrum Disorder, is a rare autoimmune disorder of the central nervous system. So that involves the brain and the spinal cord. It was historically known as Devick's disease, and a lot of people still refer to it as that. And it was known as that for over 100 years, really. It was originally first recognized back in the late 1800s and was thought to be a variant of multiple sclerosis. And it really wasn't until the early 2000s when we found the antibody that causes all the problems in NMOSD. And we really began to unpack the complex pathophysiology of what obviously is a very unique disorder. So this inflammatory disease really typically affects the optic nerve and the spinal cord, but it can affect many other areas of the brain, particularly the brainstem structures, which are located right at the very base of the brain, the top of the spinal cord. And the symptoms that people experience at the onset or during a relapse of NMOSD really depends on where in the central nervous system the inflammation affects. So it can present in many different ways, but it typically presents of one of a number of classic or what we call key core cluster of symptoms. And the two most common of those are optic neuritis and transverse myelitis. So optic neuritis is an inflammation that occurs along the optic nerve, which is the nerve that conveys information from the eye to the back of the brain where it's processed. And so when people have inflammation along this nerve, they often experience quite a dramatic loss of vision. They might have painful eye movements or a loss of color vision, and it can affect one or both eyes and can come on quite rapidly over the course of several hours to days. And the second class presentation we speak about is transverse myelitis, and that's inflammation which affects the spinal cord, and typically over quite a long segment of the spinal cord. And that can cause weakness or altered sensation, for instance, and can eventually involve and spread across their arms, their legs, their torso, even involving things like bladder and bowel dysfunction. So in this respect, it's often initially looks like the symptoms someone with MS may experience, but there are some really unique differences to NMOSD that really help us differentiate the two conditions, which is obviously vital for us to facilitate the optimal treatment for people with NMOSD.
Absolutely, Lesley-Ann. I know with my journey myself, I mean, it took 6 months to be diagnosed with transverse myelitis, and then another 6 months when they realised that my optic nerve had deteriorated, and so the diagnosis changed to NMOSD. So it's really important, isn't it, to get that diagnosis correct and as early as possible.
Absolutely. It's why we spend so much time investigating when someone first comes in with those classic symptoms. And certainly now that we are much more aware of it and have much more readily accessibility to the tests that are required to detect it, it certainly should be on the forefront of our mind when we're seeing someone for the first time in our clinic.
Terrific. This next question is something that I was very curious about once I'd been diagnosed with NMOSD. So the big question is, what causes NMOSD?
Well, we really didn't have a clear answer to this up until maybe around 15 years or so ago, when the researchers first identified what we often refer to as the NMO antibody. So it's an antibody which is directed against something called the aquaporin 4, which is a little membrane protein that sits on these finger-like projections on some cells called astrocytes within the central nervous system. And this aquaporin 4 membrane protein is found in really high concentrations within the brain, the spine, and along the optic nerve, which explains a bit as to why those areas are typically affected in NMOSD. So this antibody binds to the receptors on these membrane proteins and triggers this cascade of inflammation and inflammatory responses that eventually destroys the astrocyte and causes damage to the surrounding cells, including some things called oligodendrocytes. These are the same types of cells which are typically affected in people with multiple sclerosis, which is why we see such a similar presentation between those two diseases. It's the underlying damage that causes irreversible damage to those underlying nerves. So depending on where that occurs, it can cause some of those symptoms that we were speaking of earlier. So things like visual change, altered sensation, weakness, or bladder or bowel dysfunction. So at the end of the day, this is an autoimmune condition, so one where the immune system is being somewhat naughty and attacking its own cells, which it really shouldn't be doing, and hence why it falls under that classification of an autoimmune condition.
I have heard that NMOSD is more common in women than men. Is that true, Lesley-Ann?
Yeah, it's true. It's much the same case for many of the autoimmune conditions we see. Depending on where you are throughout the world, some suggest it's around a 3-to-1 ratio. The incidence is around maybe 1 to 2 people per 100,000, often affecting people in the prime of their lives, in their 30s and their 40s. But even that can vary significantly. There have been cases of pediatric NMO in patients who are younger than 16, and yet we also see it presenting for the first time in people that are 65, 70 years old. We know that it can occur more often in people who are of Asian or African ancestry, and there certainly is a growing interest and supporting research into the various genetic predispositions developing NMOSD. So in other words, is there a higher risk of developing it if someone in your family, for instance, has it? We know that NMOSD does cluster with other autoimmune conditions, so things like Sjogren's syndrome, celiac disease, SLE, just to name a few of them. And it's far less common than multiple sclerosis. Here in Australia, we may have 200 or 300 patients with NMOSD in total, so it's a very small community of people with this very unique condition.
It is very, very rare here in Australia and worldwide. Diagnosis for me 10 years ago was quite a slow process, but since then we've seen significant improvements.
Well, there's many things we look at as part of our diagnostic workup when we suspect someone who comes to our clinic for the first time may have NMOSD. The diagnosis we base on an international consensus, which came out in 2015 for the diagnosis of NMOSD, and it really helps us to solidify the certainty around this diagnosis because, as you said, ensuring we have the right diagnosis and that we don't miss this is really important because it does affect our long-term treatment and outcomes. So probably the first main thing that we look at is whether or not we can detect in a patient's blood those NMO antibodies that are directed against the aquaporin 4 membrane protein receptor. So that's the one that causes all the problems in the first place. And this really is critical because if those are present, the rest almost just falls into line. It almost becomes reasonably straightforward. It's when those are not detectable that we do have to go hunting a little bit more in depth. We know that not all patients with NMOSD have detectable aquaporin 4 antibodies. In fact, up to around 20 or 25% of people won't. So that's generally the first thing that we will look for. The second thing that often guides us to question whether this could be NMOSD is that initial presentation. How are they presenting clinically? Are they coming into us with a first episode of optic neuritis, or do they have symptoms that are suggestive of inflammation in the spinal cord? So those two presentations, as well as a few others, are really inherent to this disorder, that they're actually included as part of that diagnostic criteria that came out in the international consensus back in 2015. The last thing we really need to look at is all of the other possibilities of what this could be and ensure that we consider those and exclude them. So we look for things like viral infections, other autoimmune conditions, so the ones that I was mentioning beforehand, for instance, sarcoidosis, various cancers or other related conditions, anything that can present in the same way, we have to look for and exclude. Which is why at that initial presentation, when people first come to us with these symptoms, why your doctor will spend so much time with you having so many different tests as part of that initial workup. And that might include MRI scans, which really nowadays are essentially critical to making the diagnosis to assist us with considering whether NMOSD is at the top of our differential list. But it also includes other workup, things like blood tests. Your doctor may ask you to have a lumbar puncture, which is taking a little sample of spinal fluid, kind of similar to the way that women who have an epidural during childbirth have. And other diagnostic tests, and that might be with the ophthalmologist, for instance, or your neurologist, depending on what all those results show, and then what the overall picture that we're being guided from those tests shows us.
Lesley-Ann, you mentioned that there was about 20 to 25% of people that will test negative to the aquaporin 4. Do you know the reason why that's so?
Look, Debbie, it's a really good question. I'm not entirely sure I've got a clear answer for you, apart from that we do recognize there is this subset of patients whom, despite us testing for it, that they still return a negative aquaporin 4 antibody result. They're patients in whom we just simply don't detect autoantibodies in.
My next question is about the similarities between NMOSD and multiple sclerosis, but there also can be some differences. Can you tell me more about that?
Yeah, absolutely. It's true. There's a considerable overlap, certainly of the clinical symptoms that patients experience in both of these conditions. We know that there is this spectrum of inflammatory diseases that affect the central nervous system, and along that spectrum lies NMOSD, multiple sclerosis, as well as patients with autoantibodies against something called myelin oligodendrocyte glycoprotein, or anti-MOG antibodies, as some people may have heard. Really, the difference comes down to how the actual damage occurs, and where is the starting point, where's the trigger for all the inflammation that causes the subsequent damage to the nervous system. So in NMOSD, the aquaporin 4 membrane protein sits on those cells which get destroyed first, and that cascade of destruction that involves those other cells is where that primary initiation of inflammation comes from. The subsequent demyelination and the damage to the nerves can look the same as what we see in multiple sclerosis. So while the consequences and the endpoint of all these diseases is demyelination, the starting point is different. They're clinically distinct pathological process, meaning it's really important for us to distinguish and differentiate them, because the long-term preventative therapies we use will differ depending on what the root cause of the problem is. You asked about how MS and NMOSD differ, and there's certainly a number of things. So they certainly do affect the same areas in terms of the optic nerve, the spinal cord, but MS often affects other areas and in different patterns of involvement, certainly within the brain. The presentations, the pattern of involvement of inflammation that neurologists look at on the MRI scans is different between the two. Speaking in really general terms, in MS, people who have a relapse will typically recover from that, sometimes entirely, sometimes they may be left with residual deficits. But the relapses they experience tends to drive progression of underlying disability in the years to come. And that relates to the pre-existing damage that we see from previous relapses in MS. In contrast, though, in NMOSD, the accumulation of disability that people experience is almost exclusively related to their relapses. So they don't see that gradual progression or deterioration in the years to come in the same way that people with MS may experience that secondary progression. On the same account, though, patients with NMOSD may find that their relapses are more severe, and the chances of them recovering back to their baseline is less than, for instance, someone in multiple sclerosis. But that really depends on a lot of various factors, and each relapse is very unique and very different. So we try to avoid stereotyping them in that regard. At the end of the day, though, what's common is they're both chronic conditions that affect the central nervous system. They have huge impacts on your day-to-day life, both physically and mentally. And thankfully, as we continue to learn more about each of these conditions, and the more effective treatments that are available for them, as well as considerable support and resources out there for people with NMO, the more people can benefit when they are diagnosed with these conditions.
Absolutely, Lesley-Ann. I've seen huge improvements just in my time with having NMOSD, and it gives people a lot more hope that diagnosis and treatment will be prompt, and having spoken to many people in my travels around Australia that have NMOSD, there are many different effects on different people. What are some of the more common traits of this condition?
Well, people are affected by this disease really differently. It really depends on the types of relapses that they have that shape the effects that this condition has on them in the long term. As just going back to what you were saying, certainly there has been an explosion of information about this particular condition over the last 15 years. And so whilst we talk about relapses and the types of things that people may experience, we're also hopeful that 10, 20 years down the track, we won't be speaking about this as much, because as the treatments become more and more available and more effective therapies are available, that people won't be experiencing relapses as often as what they are, or what they may be if they're untreated. When we speak about the different effects that NMO can have on people, it really comes back to remembering that everybody goes through a unique journey with NMOSD. And I am a firm believer that people should not be comparing themselves to other people with this condition, because the inflammation can cause such a wide variety of symptoms depending on who it affects and where in the body it affects and when. It's never good for us to compare one patient to another, for instance, because your journey with NMOSD is very unique to you. So some of the symptoms that people may experience, though, for instance, if the optic nerves are involved, it may cause a loss of vision. So as we said, that could be in one eye, it could be in both eyes. People may recover from that, but they might also be left with more long-term visual impairments, and that could be on the milder end of the spectrum. It could also be quite severe. If the spinal cord is involved, that can cause weakness, sensory loss, or altered sensation, again affecting one side of the body or both. People might experience pain or muscle stiffness related to that, and that can be really quite severe and debilitating for some, and may affect the way that they walk around. That may be associated with painful spasms of the muscles. But it's worth remembering that there are a lot of treatments and therapies that we look at using to manage some of these symptoms. Bladder and bowel habits are really something that probably isn't spoken about enough. Some of the other things that people can experience may be symptoms affecting their bladder or their bowel habits. So that might be difficulty controlling their bladder, being able to empty and void completely. They might experience constipation, for instance. And I really think sexual dysfunction is probably one of those underappreciated symptoms that can be really so prevalent and important, and it can have such a huge impact on people's mental health. People don't necessarily want to talk about it, but it is important to recognize that that can also be affected as well. We want people to be able to engage and live a normal life, as you said, a really meaningful life, and have that quality. And so it's really important that whilst we look at therapies for reducing the risk of relapses, these things that can cause all this disability, we also think it's extremely important to manage the symptoms that people have from pre-existing relapses and be able to give them the knowledge and know how to be able to look after themselves physically, but also mentally and emotionally. And there's lots of good ways for people to do that on a day-to-day basis.
And that's so important, Lesley-Ann, to be armed with knowledge, because as we all know, knowledge is power. We also have such unique symptoms. We are all different, those with NMOSD, and a lot of those symptoms and signs that you've mentioned are quite invisible. It's very hard for other people to understand what's going on inside your body when you are looking well.
Absolutely, absolutely. And we know that many of the symptoms, as you said, are invisible, and it is really important that people not suffer in silence as well. So if there is someone that you feel comfortable speaking with, and I certainly do try approach this when I see people in clinic with NMOSD, that these are things that routinely people may experience, and there's nothing to be ashamed of at all. We want to know about them because otherwise we can't help people move forward and manage them.
Exactly. And for our last question for this episode, I'm aware and have used some terrific services and supports for those living with NMOSD. What can be done to help a person with NMOSD?
There's a multitude of things that we can do to assist people. And I think the first and most important thing, certainly from my aspect of seeing people, is make sure that we diagnose the condition early. Because in doing so, we can treat relapses early, really trying to minimize the potential long-term impact or potential disabilities that those relapses can cause. By diagnosing it early, we can also try and get people established on really effective therapies that prevent relapses in the future. We know that when relapses occur, we can't reverse or repair the damage that's already occurred. I think that's the holy grail of research nowadays in terms of finding a way to recover from the damage and from the scarring that can occur from inflammation and demyelination. But we really can aim to significantly minimize that risk of relapse in the future. And at the same time, supporting people to manage the day-to-day symptoms that they experience. And as we said before, giving them the knowledge and the know-how moving forward to be able to arm themselves with that capacity to look after themselves. So I talk about empowering people really to understand their disease. I think that's immensely important. That they can be actively involved in their ongoing management. So usually someone with NMOSD, once diagnosed and established on treatment, we encourage to have regular follow-ups with your specialist neurologists and various other specialists involved. So that might be the rehabilitation specialist or the ophthalmologist, for instance. We look at using medications to relieve various symptoms that they may have to improve their quality of life. We want to monitor for recurrence of that, so that includes regular MRIs. We also see people for driving clearances, for instance, if they've had their vision affected by previous NMOSD relapses, to ensure that they're still able to drive safely. We often involve the input from the allied healthcare teams and the rehabilitation teams, the physiotherapists, the exercise physiologists, the occupational therapists to really maintain their physical health and safety. And I am a firm believer in never underestimating the importance of having a really good GP that you feel comfortable with, that you can speak openly with, as a first port of call for many other things that may be required.
I think it's really important, Lesley-Ann, to surround yourself with the people and supports that support you and that you do feel comfortable with. Absolutely. I think that's really great advice.
Yeah. And I think we're very lucky as well. We live in a society nowadays where we have access to so many supports for people that have, NMOSD. We've got resources online, whether those are websites or online support networks, Facebook groups, things like that, as well as all the additional supports. And I guess I realize we've spoken about a lot of the symptoms people can have and the impact that can have as a result of relapse. But the truth is, if we remember, our knowledge about NMOSD really has dramatically exploded in the last 15 years, and the potential treatments have grown even in the last 2 or 3 years. And we've gone from using conventional, generic immunosuppressive treatments, which were never really tried or tested in people with this particular condition. And we've now gone to identifying a number of crucial targets along that pathway of inflammation. We've got various international clinical trials with various medications that have shown an immense effectiveness at reducing the risk of future relapses for people with NMOSD. And that really has changed the landscape of therapy moving forward. And whether people are treated with those with these newer treatments or the more traditional, conventional immunosuppressive therapies, I think it's one step forward for a lot of people in the right direction to managing this in the long term, which we never had available 15 years or so ago. So everything is changing, and certainly rapidly in the last few years regarding this condition.
That's really good to know. Thank you, Lesley-Ann, for your time, the wonderful information that you've been able to share with us, your insight into unpacking NMOSD. That concludes this episode, but I look forward to talking to you in our next episode about recognising a relapse. Thanks very much.
We hope you have enjoyed listening to this NMOSD Your Way Global podcast. For more information about NMOSD and access to support and resources, please read the podcast description. What you have heard in this podcast may not be reflective of your own experience and does not replace the advice of a healthcare professional. If you have any concerns or specific questions about NMOSD, please speak to your physician.